This is the lecture on cerebral palsy. So first we're going to start by talking about what is cerebral palsy. Before we get started, we need to discuss what cerebral palsy is. As a broad definition, cerebral palsy is a non-progressive disorder caused by brain injury while the child's brain is under development. This can be due to many things, such as lack of oxygen, physical trauma, infection during pregnancy, and severe jaundice. Cerebral palsy primarily affects body movement and muscle coordination, where the child will often have excessive tone that commonly presents in the ankle plantar flexors, the hip flexors, the hip adductors, and the hamstrings for the lower extremity. In the upper extremity, the areas with increased tone are often the elbow flexors, the shoulder internal rotators, the the forearm pronators, and the wrist flexors. Along with excessive tone in the extremities, most children will also present with reduced tone, also called hypotonia, in the core and abdominal regions. Children with cerebral palsy can also develop secondary muscular components, including muscle contracture, bony torsion, hip dislocation, and spinal deformity. Most of these secondary components are caused by the physical growth, weakness, and many other factors. It is also good to keep in mind that the severity and involvement of cerebral palsy can vary among people and children. Therefore, it is important to know that each patient will present slightly differently. While they may present differently, each child with cerebral palsy will experience neuroplasticity. If you aren't sure what neuroplasticity is, it is the development of new neuronal connections that bypass an affected area in the brain. For example, you can think of this as a traffic jam. If you are on the road and the road is blocked by traffic, you can take a side road to get to your destination. The nerves can grow to develop side roads so they ultimately arrive at the destination, which allows the patient to have access to areas of their brain that they potentially would not because of the damage that has occurred to their brain tissue. There are two main ways to classify the impairments of cerebral palsy. These are called descriptors. The first descriptor is typically the movement difference. The movement difference describes the presentation of movement. The different types of movements are associated with damage to different parts of the brain. The movements are involuntary and cannot be controlled by the patient. Spastic cerebral palsy is the most common movement presentation, and it presents with quick, jerky movements. It is a result of damage to the cortex of the brain. Dyskinetic cerebral palsy describes a movement that appears like an uncoordinated dance. It can also be described as writhing movements, and it is a result of damage to an area of the brain called the basal ganglia. The last movement difference is ataxic cerebral palsy. Ataxia describes abnormal, uncoordinated movements and is typically a result of damage to the cerebellum of the brain. You will see the term ataxia again in the stroke unit regarding strokes that occur in the cerebellum of the brain. The other classification to talk about is the distribution of impairments. This is called the topographic distribution. If a patient with cerebral palsy has symptoms on one side of their body, in both their arm and their leg, it is considered hemiplegia. You will also see this term when we get to stroke. The hemiplegia is present on the side opposite of where the brain damage occurs. In diplegia, the legs are more affected than the arms. Again, this is a result of the area of the brain that is damaged. In diplegia, the area that is more damaged is responsible for leg function, which is why the legs are more affected than the arms. Quadriplegia describes arms and legs are both involved, and it is indicative of a damage in a larger area of the brain. Typically, these terms are paired to describe the type of cerebral palsy that a patient has. For example, the patient may have spastic hemiplegia, spastic diplegia, or spastic quadriplegia, or any combination of those terms.
In America, we use the Gross Motor Function Classification System as a way to help us classify the different levels of CP. We can also abbreviate this as GMFCS. This classification system is specific to cerebral palsy and classifies the patient's functional level in regards to their everyday functional capabilities. It also takes into consideration the child's need for handheld mobility devices, wheelchairs, while also considering their quality of movement. We can use this to help us set goals for the patient and determine what functional tasks need the most attention. The important thing to consider when using this scale is that these descriptors are specific for children between the ages 6 and 12. For our purpose, we are going to use the age 9, which is right between the ages 6 and 12, as our cutoff age to see major functional improvements in these children. This means that when a child is younger than 9, they are still going to have significant ability to improve levels. Once they reach approximately 9 years old, their GMFC level is typically set. This highlights the importance of really aiming high when setting goals for your younger CP patients. For example, a 5-year-old who is currently a GMFCS level 3 using handheld mobility for shorter indoor settings and a wheelchair for longer distances may be capable of moving to a level 2 where he would be able to walk short distances without any external support and only need handheld assistance for longer distances. Now that we have introduced you to the GMFCS classification system, we are going to dive into each of these GMFCS levels and discuss the specifics on clinical presentation, function, prognosis, and treatment options. GMFC level 1 is the highest functional level of cerebral palsy. A child in this category has minor deficits and may demonstrate increased tone in their unilateral arm and leg, or possibly in just one arm or leg. It all depends on where the brain damage has occurred, like we discussed earlier in the general classifications. Children with GMFC level 1 often have the same balance and coordination deficits, but are overall very functional. They can run, jump, and play sports, and should be encouraged to participate in all those activities. It is important to note that although, as we learn, cerebral palsy is a non-progressive disease, the child's tone may increase in particularly stressful situations or when they are doing more than one task at a time, which is called dual tasking. For example, if you refer to our picture in the corner of the page, you will see a boy climbing the stairs while holding the box. This could be a challenging task for a child, causing increased tone and increased difficulty for that specific task. Another example would be asking the child to count while they are climbing the stairs. Can you see how the demands on the child increases? Because not only is it a physical challenge for the child, but it is also a mental challenge. This is important to keep in mind when working with cerebral palsy kids and can be used as a good rehab strategy. For instance, I treated a 5-year-old with spastic hemiplegia cerebral palsy who is a GMFC level 1. He could go up and down the stairs without adult assistance, but as soon as you asked him to carry his school supplies up and down the stairs, he required a handheld or railing assistance. Then when you asked the child to carry his school supplies and carry on a conversation at the same time while walking up the stairs, the child needed even more assistance to complete the task because it was just too much information for him to process. For prognosis, as we discussed about earlier, the child's age will help determine how much potential the child has for making gains. A child older than 9 will likely stay where they are at functionally on the GMFCS level scale. But a child who is younger than 9 has a significant chance of becoming a higher functioning GMFC level 1. So for our treatment focus on this level, it should include functional activities such as walking outdoors, climbing stairs, participating in sports, running, and jumping. Speed, balance, and coordination should be things to emphasize to help challenge these children in order for them to increase function and keep up with their peers. Also, stretching and range of motion activities may be indicated if the patient is presenting with any particular tightness in these muscle groups. So now moving on to GMFC level 2, this is going to be a step below GMFC level 1. A child with GMFC level 2 is still able to participate in independent walking when walking short distances, but this child may have some walking limitations when they have to attempt longer distances. These children are similar to level 1 in the sense they will also have increased difficulty with dual tasking or when their base of support or level surfaces are challenged. Children with GMFC level 2 will be limited in their ability to run and jump and may require an assistive device for additional assistance from an adult to complete the task. Along with running and jumping, GMFC level 2 patients will need assistance from the railing to climb stairs or curbs, as you can see in the picture on the bottom of the right page. So for GMFC level 2 prognosis, it is going to be similar to GMFC level 1. A child greater than the age of 9 will likely be set at the GMFC level 2, but a child younger than the age of 9 will have an increasing chance of becoming a GMFC level 1 or a high-functioning GMFC level 2. So for our treatment focuses for GMFC level 2, we will want to focus on balance, gait, and strength training. For children who are younger than 9, you can work towards treatment focuses for a GMFC level 1 patient. But for children over the age of 9, our biggest focus is to maintain independent walking, and in doing so, we want to work on lower extremity functional strengthening activities, balance, and coordination. While these kids are limited in their running and jumping capabilities, this is still something we want to work on. So now we are on to GMFC level 3. GMFC level 3 patients present with a reliance on an assistive device in order to do most daily activities, and may even need a wheelchair for when attempting long distances, as shown in the picture on the bottom of the page. These kids will require railings with supervision or some physical assistances when climbing stairs. These children may also have difficulty with independent sitting without the use of external support, such as their wheelchair or leaning up against a tree or a wall. Since these children often need a wheelchair for long distances, they will also require the minimal to moderate assist to get in and out of their wheelchairs. So again, with prognosis for a GMFC level 3, any child greater than the age of 9 is often set at a GMFC level 3. But child younger than 9 has an increased chance of becoming a GMFCS level 2 or a more independent GMFC level 3. So again, with our treatment focus for the GMFC level 3, we will want to be working on postural strength in mainly seated positions, but also standing positions. There will also be a focus on upper extremity strength to allow for more independent propulsion or mobility when using wheelchairs. While children in this level often use wheelchairs for long distances, it is still important to work on lower extremity strength and balance for standing and walking activities, especially if the child is younger than 9 years of age, because these are the children who have the greatest chance of improving their functional abilities. So, on to GMFC level 4. These children are dependent on their wheelchairs as their main means of independent mobility. They can walk short distances but will be required assistance, as you can see in the picture on the bottom of the page. These children will require adult assistance for most of their functional activities as well, and are dependent on others' assistance to ascend and descend their stairs. While these children are in wheelchairs for long distance tasks, these children have decreased trunk, pelvic, and head control, which require them to need adaptive seating equipment to assure safety and comfort. So as we continue on with our prognosis, a child older than the age of 9, they are likely going to be set at a GMFC level 4. While while those who are younger than the age of 9 have an increased chance of becoming a GMFC level 3 or becoming a better functioning level 4. In a sense, they may become less dependent on others when doing functional activities. Our treatment focus for GMFC level 4 will revolve around participation and function. Our sessions will involve working on sitting postural control to allow for better interaction with the child's peers. Standing tolerance and balance will also be areas to work on in order to avoid contractures or other secondary problems to arise. These children can walk as well with assistance, and this is particularly a beneficial task when the child is younger than the age of 9. So for our last level, we have the GMFC level 5, which is the lowest functioning level of cerebral palsy. These children will be in a wheelchair for all activities and will require extra equipment to improve the child's sitting posture and provide support for proper head alignment. While these children are often confined to their wheelchairs, it is good to have time on the floor even though they have minimal floor mobility. The prognosis of GMFC level 5 is the same as all the other levels. If a child is older than the age of 9, then they are set at a GMFC level 5. But if the child is younger than the age of 9, then they have a better chance of moving up to a GMFC level 4 or improving to a more interactive level 5. Our treatment focus for GMFC level 5 will look at more long-term adaptations that will allow the child to more easily interact with his or her environment. These adaptations can include proper wheelchair positioning, good awareness, and maintenance of range of motion and pain management. Alright, so here are some general treatment ideas for all classifications of cerebral palsy. The most important thing to consider when determining treatments is to focus your treatment around what the child likes to do. Make a game out of it. Make it fun for them. Research shows that when a patient is engaged in your treatments are more effective and the child receives greater benefits. While it may be difficult to think of fun activities that cover each of these treatment ideas, at least make an effort because the rapport you build with the child and family will help your treatments be more effective and easier on you and the patient. In lab, we will be mainly covering the first 4 topics here of long-term stretching, strengthening, postural control, and improving balance. While those will be the main topics covered, we are going to take time real quick to go over each of these topics and share the importance of each of these treatment ideas. So first of all, long-term stretching. This will be an important treatment to alleviate secondary muscular contracture and to allow child to remain functional. With that in mind, research shows stretching and elongation of muscles needs to occur several hours per day in order to be effective. Therefore, we will be exploring a couple different ways to implement stretching in these children's daily activities, and these things we can teach caregivers and family to implement as well at home. For strengthening, there are muscle groups that are typically weak in children with cerebral palsy, including the hip extensors and abductors, the back extensors, and the ankle plantar flexors. There are many exercises and fun activities to work on these muscle groups, and we will be discussing some of these activities in lab, and we'll be practicing them. Posture control is going to be important for those children who are categorized into lower functioning GMF-CS levels, such as 4 and 5. Balance is going to be good for those children who are categorized in high functioning GMFC levels, such as 1, 2, and 3. Balance is going to benefit a child walking and standing postures and will overall help them participate in activities with their peers. Some ways to work on this is to adjust the base of support or change the compliance of the surface the child is standing on, which will all be the activities we will work on in lab. Optimizing physical function is important in keeping children involved and able to interact with their peers. It is also important for these patients to get the exercise to help with cardiovascular endurance and reduce the chances of weight gain. Maximizing independence is also going to be important because the more independent the child is, the more freedom the caretaker and the child will have. It also means that the child can be more active and be able to participate in activities and not feel left out. Gait training is going to be especially important in those higher functioning GMFCS levels. The more these children walk, the longer they will be able to walk for and stay active and have less secondary problems. Orthotics are another good option for treatment and can help with foot clearance and gait, which will hopefully help the child be more active and allow for participation in activities. Orthotics can also help minimize contractures, especially in the ankle. Weight control is very important as well, because the heavier the child is, the more that gravity is going to play a part and cause them to go into what we would term a crouch gait. We will discuss more on crouch gait and movement scripts during our live lectures and labs so we can demonstrate what these gaits look like. Pain management is for more advanced GMFCS levels is very important because those kids who are wheelchair bound can be at risk for sores, contractures, and other aches and pains. We can help manage pain with good range of motion activities and proper wheelchair seating, which we will also cover in lab. Along with pain management, you need to consider adaptive equipment for low functioning GMFCS levels, because these children are going to have little head and trunk control, which is going to make it difficult for them to sit in a chair on their own. Using adaptive equipment will allow for good positioning and safety of the child. Overall, when working on all these areas, it is your responsibility as the PTA to determine the correct amount of support the child needs while still challenging the child and providing a safe environment for them. All right. So when you are examining a patient with cerebral palsy, the first and most important thing to do is to observe their function. Observe how they move in their environment and how they complete different tasks, such as rolling over, sitting, moving from sit to stand, walking, and going up and down stairs. Depending on the functional level of the child, they may or may not be able to complete the higher level tasks, such as walking or climbing stairs. This information can help you to determine what tasks are important to the child, can help you determine areas of strength and weaknesses, and can also help you set therapy goals for the child. A couple examples of things to note are, when the child is sitting and playing with a toy, how much support do they need? Are they able to lift both hands up to manipulate an object, or do they need to keep one or both hands on the ground for stability? Are they able to long sit with their feet out in front of them, or does sitting cross-legged or in a W sit give them the stability that they need? Is the lack of stability because of increased or decreased tone, or is it a strength issue? This can then guide your treatment. Other useful exams findings include range of motion. This can be useful in determining wheelchair positioning and whether stretching is helpful. Strength, a more objective measure of strength than functional tasks such as muscle testing. Foot alignment, which can help determine if AFOs are required and can help to set goals related to gait. Tone, which can help you with positioning, whether it be the wheelchair, lying, or sitting. And then wheelchair positioning is important in preventing contractures from occurring. One of the most important things to encourage with children who have cerebral palsy and their caregivers or families is that being upright and interacting with the world is very important for their development. This means that depending on the child's functional ability, the child should be encouraged and allowed to be sitting or standing as much as possible or as tolerated. Some benefits of sitting and standing include increased bone density, digestive health, increased blood flow, especially in the lower extremities, increased muscle strength, incoming sensory input from the skin, muscle, and joints, and even perhaps the most important, upright interaction with the world. When getting a child with cerebral palsy standing or sitting, we need to determine the correct amount of support needed. If they are new to sitting or standing, they could fatigue rather quickly and it can be painful. You may need to start out by having them in a sitting or standing for 5 minutes, 3 times per day, and eventually increase the times or frequency as they can tolerate. On the right, you can see a young child standing in a stander made out of cardboard. This could be something that could be used to help increase their tolerance. Here are some things to consider when you are getting a child into sitting or standing. If you have them in an adaptive device, such as a sitter or stander, be sure you are considering how they are tolerating the device. As we talked about on the last slide, they may be fatigued or painful. So take the time to ensure they are comfortable in the way that they are positioned. Skin integrity is another consideration. If their skin is in contact with the device for an extended period of time, it could start to cause wear on the skin and even cause a pressure sore. To avoid this, use cushions, blankets, and padding to pad the area that are exposed to contact with the device. The child should also have frequent positioning changes when they are in the device. If they are unable to perform these position changes to relieve pressure, you may need to help them to change positions. It takes significantly more energy for a child with cerebral palsy to maintain these positions than it does for a child without cerebral palsy. This is an important consideration when determining how much time the child should be spent in these positions. This is another reminder to check in with the child if possible to see how they are tolerating the device. The device must be relatively easy to use for the family and caregivers. If the device takes too long for the child to get in and out of, it is likely that the family will not utilize it. Getting a child into sitting and standing presents many treatment options. You can have them shift weights and reach, play games, or even do schoolwork in these positions for endurance. Again, it is very important for them to socialize with other kids and adults, and being in these positions should help encourage that interaction. Also remember that if you do not have a sitter or stander available, you can help by supporting the children in those positions, similar to how the PT is in this picture. You might be wondering how long should we have the children be in these sitting and standing positions? Research shows that 60 minutes of standing each day for a child with cerebral palsy increases bone density. If the child is unable to tolerate a whole 60 minutes, you can break up the time they spend in sitting or standing into shorter increments, such as 15 minutes for 4 times throughout the day. Prognosis and outcomes are important in goal setting, as well as helping parents, caregivers, or children understand what their function could potentially look like. In the research, the factor that best predicts whether a child with cerebral palsy will walk or not is cognition, the child's ability to learn and understand. Children with cerebral palsy who are functioning higher cognitively are more likely to walk. Another predictor of walking that can be determined when the child is relatively young is independent sitting. If a 2-year-old child with cerebral palsy can sit independently, they have an increased chance of walking by the time they turn 8 years old. If they are not sitting by 3 years old, they have a decreased chance of walking by the time they are 8 years old. When looking at adults with cerebral palsy, half of those with hemiplegia and 33% of those with diplegia maintain walking throughout their life. As a child ages, their muscle strength and endurance are not able to keep up with the increase in body weight. It is important to encourage activity and good nutrition as a child with cerebral palsy ages to attempt to decrease this discrepancy in body weight strength change as much as possible. Other prognostic factors and outcomes include the following. When a child reaches 9 years of age and is at the lower functioning level of cerebral palsy, 3, 4, and 5, their skills typically start to decline. This is often due to that shift in body weight to strength ratio that we talked about on the last slide. It is important to note that people with cerebral palsy can be very functional. As you can see here, 31% live independently, 12% are married, 24% achieved a tertiary vocational level of education, and more than a quarter of them achieved a paying job. There are some characteristics that can make it more likely for a person with cerebral palsy to have a job. Those include mild physical involvement, good home support, education, vocational training, and good cognitive skills. All these factors are reminders that we need to aim high for these children who have cerebral palsy. Their disability should not limit them from achieving their dreams. Alright, so on to wheelchair seating and positioning. This is important with cerebral palsy because it can help to prevent them from developing contractures. The first thing you should consider when determining the proper fit of a wheelchair is to determine whether the malalignment is a fixed or flexible. A flexible malalignment can be moved with an external force to be aligned. A fixed deformity cannot be moved to be aligned. Our goals when determining proper wheelchair seating are different depending on whether the malalignment is fixed or flexible. If it is flexible, our goal with positioning is to realign the body to maximize stability and function. If the malalignment is fixed, you need to accommodate the chair to be supportive as possible in their malalignment, with the ultimate goal of being to position the head in neutral. Before determining the correct wheelchair position for a child, you must consider the range of motion in their hips, knees, and ankles. Be sure to measure the range of motion, as this will be used to determine where or how to position the wheelchair. When sitting in a wheelchair, the angle of the child's hips must be at 90 degrees or greater if they have the available range of motion to be in this position. The next consideration is hamstring length. Look at the picture to the right of the wheelchair. If a child has tight hamstrings, they are not going to be able to extend their knees enough to get their feet onto the footrest. If they are positioned with too much flexion, it could put them at a further risk of contracture. Ankle range of motion is also important to consider. See the picture in the top right? If the child has tight plantar flexors, which often occurs in children with cerebral palsy, you may need to position them more like the picture of the feet on the left, where if they have more flexibility, the picture of the feet on the right will cause a stretch on their plantar flexors and could help prevent contractures. Just as we talked about with the sitting and standing, be aware of the areas of skin that are in excessive contact with the wheelchair. Note whether the patient is able to perform pressure relief or if they will need a caregiver to support with these tasks. Also, when positioning a child in a wheelchair, it is important that we do not position them at the end range of motion. You should position them 5 to 10 degrees less than their end range, as positioning them at the end range could be painful and could also cause malalignment in other areas. When determining positioning for a child in a wheelchair, these are goals you should keep in mind. It is important to facilitate trunk stability and alignment, as having a solid base of support will allow for improved function with reaching and other tasks involving the extremities. You may need to add lateral support, chest straps, or seat belts to ensure proper alignment in the chair. As emphasized through this presentation, getting a child with cerebral palsy upright allows them to socially interact with their peers, families, and others. This is very important for their development and well-being. Other goals of seating and positioning are to minimize impairments that interfere with function, minimize seated pressure to avoid sores, and to consider accommodation versus realignment, as we talked about earlier in our discussion of fixed versus flexible malalignment. There are several options for managing tone, most of which are very expensive and have limited availability. As physical therapists, we will be stretching patients but perhaps more importantly, since it takes greater than 6 hours per day to make a change in muscle length, we will be training family members and caregivers how to safely stretch the child with cerebral palsy. Orthoses and bracing may be an option for the child. In the top picture, there are 3 ankle foot orthoses, also known as AFOs, that can be used to manage tone. Baclofen and Botox are pharmacological options that can provide limited relief from increased tone. Botox requires injections every 90 days, and Baclofen involves implanting a pump in the child that needs to be refilled with medication every 1 to 6 months, depending on the child's dose. These are becoming more popular in the United States, but unsure of the access in Africa. Selective dorsal rhizotomy is a surgery done in the lower spinal cord in which certain nerve fibers are cut, which will allow those muscles that have increased tone to no longer have that increased tone. In the bottom picture, casts are being used to manage this child's tone. In our labs, we will be covering the stretching portion as well as covering casting and AFOs in our prosthetics and orthotics labs. So to wrap things up, these are the points that we hope you remember from this presentation. It is important to maximize participation with other children and encourage their function in daily life. To go along with this, it is important for them to be upright and interacting with others, as for this is important for development and leads to better outcomes later in life. We want to minimize orthopedic impairments and contractures as much as possible. By positioning them well, we can hopefully prevent these as often as possible. It is important to remember that many of the impairments of cerebral palsy can be painful. We want to be sure that we are managing the patient's pain control for the long term. We also need to manage their orthotics, adaptive equipment, and their access to care. We should be advocates for the patients to help them receive the devices and care that they deserve. Remember that these patients often have many other appointments and also have a life of their own to live. If now isn't the best time for them to be involved in therapy, be mindful of that. Remember that the patient-family goals are the goals that really matter when you're treating a child with cerebral palsy.